Hello, everyone, and thank you for joining us to learn more about current clinical studies in ADPKD. I am Nicole Hart, Director of Community Engagement at the PKD Foundation, and I will be your host throughout the webinar. Joining me on the panel is Elise Hoover, our Director of Research, and Chris Rasconi, our Chief Research Officer. We will get started with the presentation in just a moment, but first I have a few announcements. All attendees will remain muted throughout the presentation to ensure good audio quality for all viewers. We are recording this webinar and will post the recording on our website within the next few days. If you have questions during the presentation, please type your questions into the question box located in your control panel at the bottom of your screen. We will do our best to address as many questions as possible during the Q&A session immediately following the presentation. This session is designed for informational purposes only and will not include information on the treatment or diagnosis of PKD. As you listen to this information, if it sparks questions for you regarding your treatment, you are encouraged to speak with your medical professional. I am delighted to introduce you to our speaker, Dr. Maria Arrazabal. Dr. Arrazabal's primary research is focused on understanding the pathogenesis and molecular mechanisms of renal injury in ADPKD with the purpose of identifying early disease biomarkers for risk stratification, prediction of disease progression, and new pathways for therapeutic interventions. Dr. Arrazabal is an assistant professor of medicine and a faculty member of the Mayo Clinic PKD Center. Her contribution to the field of PKD research includes the development of an imaging classification for ADPKD patients, which is broadly used for selecting which patients with ADPKD to treat. Her research program is funded by the National Institutes of Health and the PKD Foundation. Areas of particular interest include the study of mechanisms leading to oxidative stress, the antioxidant response, and associated metabolic abnormalities, as well as the development of statistical models to determine disease severity and predict renal function decline in patients with ADPKD. Dr. Arrazabal, welcome, and I'm going to turn the presentation over to you.
Thank you, Nicole. Let me start. Good evening, everyone, and thank you very much for attending this PKD webinar. Thank you very much, Nicole, Elise, and Chris for having me here and giving me this opportunity to share my studies with the PKD patient community. So today I will be sharing with you two of our clinical studies that we have currently ongoing at Mayo Clinic in Rochester, Minnesota. And they are about oxidative stress and the antioxidant response as biomarkers in ADPKD patients. So before I get started with the webinar, I just want to say that I have no financial relationships to disclose and that the funding provided for these studies is by the NIH and the PKD Foundation. Last but not least important, to make sure that we all acknowledge that participating in these research studies, it is only your choice. Being in this research study is your choice and you choose to participate. You will not lose any of services, benefits, or rights that you will normally have if you choose not to take part in these studies. Before getting into the webinar, I would like to share some outline that I prepared for the presentation. So first, I will be sharing some of the background, which will include why we are doing this research and specifically also why we are focusing on oxidative stress and the antioxidant response. Then I will share some of the research objectives of these studies. So mainly what we are trying to accomplish, what is involved, what participation in these studies looks like. Then I will share some key information about the studies. And finally, I will do a brief summary and we will open for questions. So We have had many significant progress in the last decades in the research of polycystic kidney disease, but we still have a very significant challenge from the medical perspective in the care of patients with ADPKD, which is the lack of an early biomarker that can help us in predicting disease progression at early stages of the disease. This is in part to the large disease variability that we see in patients with ADPKD, which is in part due to different genes being associated with the disease. We know that there are mainly two genes that are responsible for the disease, PKD1, which is responsible for approximately 80% of the cases, PKD2, about 15% of the cases. And we know that patients that have a mutation in the PKD1 gene have a more severe disease compared to patients that have a mutation in the PKD2 gene, which usually have renal kidney failure at about 20 years later compared to patients with a mutation in PKD1. But in addition to being more than one gene involved in the disease, there are hundreds of different pathogenic mutations that cause disease variability. And this is illustrated by this example, where you can see three different patients, the three patients with all of them with a mutation in the PKD1 gene. And as you can see, they are all of the same sex and all at the same age. However, you can see that the three different patients have very different grades of disease severity, with this patient in here having a much smaller kidney volume compared to this patient and compared to this other patient at the same age. So this is one of the reasons why it is so difficult to determine or predict disease progression at early stages of the disease. But the other factor that affects in the ability to predict disease progression is the natural course of the disease. And so peculiar to patients with ADPKD, we know that in patients with ADPKD, the renal function, the kidney function, remains normal during most of the course of the disease, and until there is a decline in the kidney function. And so if you want to detect disease progression when there is a decline in renal function, if we use markers of renal function, it is easy at these stages. However, if we want to detect disease progression or predict disease progression at these stages early on the disease, when the renal function remains within normal limits, it is very difficult because we are not going to be able to detect changes in renal function. Luckily, in recent years, thanks to the advancement in imaging techniques, and in particular to the CRIS study, we know that during this time, during early stages of the disease, the kidney volume is growing. And so because of that, in the CRIS study particularly, we have seen that kidney volume can predict further increase in kidney volume and also decrease in GFR. And so that is why at early stages of the disease, using total kidney volume or TKV has become one of the best markers that we can use to detect and predict disease progression at very early stages of the disease. So based on that, we know that the average growth of the kidneys based on the CRIS study is around 5% per year. But we also knew that not all the patients were growing the kidneys at the same rate. And we know that there are patients that have a higher rate of kidney volume increase and patients that have a lower rate. And that is why, because of that, using the total kidney volume adjusted by the patient's height and creating limits for each specific age, we developed more recently an image classification that sets different theoretically kidney growth rates. And what we were able to detect is that in patients that have what we call class E, have a much faster rate of kidney volume increase, and that correlates with a much faster decline in renal function compared to patients that have what we call a class C, that have a moderate kidney growth rate and a moderate decline in renal function, and compared to patients that we call 1A, that are the ones who have the mildest disease and that they have the lowest kidney volume growth rate and the lowest decline in renal function. However, the classification still uses kidney volume, and the main problem with kidney volume, or although it is the best biomarker that we have at the moment to predict disease progression or severity in patients, it does focus on later stages because it focuses on already anatomical damage that is present in the kidneys. It also takes time to observe the changes in the kidney volume, and more importantly, it requires imaging and it's costly. But also it does not give us an understanding on the mechanisms that are making those kidneys grow. And so that is why we say that we are still lacking a practical early marker that can allow us to monitor disease progression in patients with ADPKD. So why focus on oxidative stress and the antioxidant response? Let's first give a few definitions so we can make sure that everyone is on the same page. So oxidative stress reflects an imbalance between the production of reactive oxygen species, or ROS, and the antioxidant response. The problem is that everyone thinks as ROS as a bad thing, but ROS are a group of chemically reactive oxygen molecules that are in reality normal byproducts of the oxygen metabolism and have an important role in normal cell function. Anyone, just by the fact of living, respiring, will generate ROS, and we want to have some ROS. The problem is that when there is a dramatic increase in ROS, that is what causes the cellular damage because it reacts with proteins, lipids, DNA. But so what is that it's causing oxidative stress then? It is an increase in the production and or a decrease in the antioxidant response that leads to oxidative stress, not ROS per se. So in addition, oxidative stress has been commonly linked and observed in several kidney diseases, including ADPKD. And there have been previous studies that have shown in animal models and in patients with ADPKD that oxidative stress is present early on the disease. However, the mechanisms that lead to oxidative stress, including ROS generation and the elimination, still remains elusive. So why study NOX4 then in ADPKD? So NADPH oxidase 4, or what we call NOX4, and the mitochondrial respiratory enzymes are the major sources of endogenous ROS in the kidney. But in addition, at physiological levels, NOX4 generates ROS that participate in cell signaling and have a protective role. So it is the increase in NOX4 expression that will lead to an increase in ROS levels, and that can result in oxidative damage and ultimately cell death. Increase in NOX4 has also been associated with kidney diseases, including diabetic nephropathy, and we have also recently published a study in PKD that shows that there is an increase in NOX4. But things are definitely not that simple. So this schematic representation shows what I mentioned before, that this is the enzyme NOX4, that it's bound to cell membranes and the membranes in the organelles also, that generates hydrogen peroxide, which is a type of ROS, which we do want to have at normal or physiological levels because it contributes to the normal redox signaling and actually has a protective role. It is when there is an increase in this enzyme, in the expression of the enzyme, that generates an increased levels of ROS, and that results in impaired redox signaling and damage. But when there is a decrease also, there is an impair in the redox signaling, and that also causes damage. And that is why it is so important to determine how is NOX4 in ADPKD at different stages of the disease. And we are trying to find the sweet spot or the sweet level between being not too high and not too low. And we are currently doing some animal studies where we are treating some animals with NOX4 inhibitors and trying to determine at different stages of the disease how low levels of NOX4 are. So why study NRF2 in ADPKD? NRF2, or the nuclear factor erythroid-like 2, is a transcription factor, which is basically a protein that has the capacity to bind to certain sections of DNA that directs or protein synthesis. So in the case of NRF2, the DNA that regulates is all the antioxidant enzymes. So that is why it is called the master regulator of the antioxidant response. So basically what happens is, under normal conditions, NRF2 is tightly regulated by many mechanisms, but one of those could be KEAP1, which signals NRF2 for destruction. And when that happens, NRF2 doesn't go to the cellular nucleus, and then the antioxidant response is off. But when there is an increase in certain substances, for example, reactive oxygen species, but also some other substances like fumarate or nordic guaritic acid or NDGA, it has been shown that those substances have the capacity to modify the NRF2 regulator. And what that happens is that NRF2 doesn't get signaled to be destroyed, and it translocates to the nucleus and turns on the antioxidant response. So you would think then that a decrease in the antioxidant response is damaging, and it has also been associated with oxidative stress and kidney fibrosis. But again, things are not that simple. And there has been animal studies, and we know that in patients, an increase in the NRF2 response has been associated with cyst in the kidney. So this is a disease, fumarate hydratase deficiency, that has been associated in humans with subtype of rare form of kidney cancer that it's also associated with cyst. And these images in here are from a mouse model that was developed to study fumarate hydratase deficiency. And as you can see, this mouse model also developed a cystic phenotype in the kidneys. And the way the investigators found out that this was associated with an increase in the NRF2 response. But also, if you remember that I mentioned NDGA, that it's one of the molecules that can affect the regulation of NRF2, before we had all these fancy genetic models to study ADPKD or polycystic kidney disease in general, in the 80s, they were using chemical models, and it was found that the administration of NDGA causes cyst formation, and that was used to study cystic disease. And this is how the kidneys of a genetic animal looks like. So bottom line, it's not that simple, and that is why it is so important that we are performing some, again, animal studies also to determine how is the NRF2 response at different stages of the disease in animals. And we are testing some drugs also to see how can we modulate the NRF2 response. But bottom line, at the end, nothing will help in the study of ADPKD if what we find in the animals or in the lab doesn't work or doesn't really reflect what happens in the patients. So that is why we have at the moment 2 ongoing clinical studies that are focused on the oxidative stress and the antioxidant response for biomarker discovery in patients with ADPKD. So one of the studies is the characterization of the NF2 response in patients with ADPKD, what we call in short NF2 study. And the other study is NOX4 mitochondria and related biomarkers in ADPKD, which is what we call the NOX4 study in short. The main objectives of these studies is to evaluate oxidative stress and the NF2 antioxidant response in early stages of ADPKD, while trying also to identify candidate biomarkers. And then the other study is to determine the value of NOX4 markers of oxidative stress and mitochondrial injury and function, and oxidative stress as real-time biomarkers to assess disease severity in patients with early ADPKD. So who is funding these studies? The NRF2 study is being funded by the NIH, and the NOX4 study is being funded by the PKD Foundation research grant. Who is eligible to participate? Patients that have a previous diagnosis with ADPKD, subjects that are male or female that are between 18 or 30 years of age for the NRF2, or 18 and 40 years of age for the NOX4, patients that have an estimated GFR above 60 for the NRF2 or above 90 for the NOX4, patients that have the ability to provide informed consent. Who is not eligible to participate? Patients that have a typical presentation of the disease. Before I move forward, I would like to share with you what we call typical and atypical ADPKD. So typical, it's what we define by patients that have bilateral diffuse distribution of the cystic disease in both kidneys, where all the cysts contribute similar to the patient kidney volume, compared to what we call atypical, which is the minority of the cases, as you can see, about 5%, where there is atypical presentation. And that could be patients that present with unilateral disease, asymmetric, segmental, or loop-sided, but also patients that have unilateral atrophic presentation or bilateral atrophic presentation. And the idea of making this distinction between typical and atypical is because in patients that have typical presentation of the disease is in the ones that we found that the kidney volume is the one that reflects the most how the disease is going to progress, compared to patients that have atypical presentation where the kidney volume is not really a good marker to predict how the disease is going to progress. And that is mainly because in these patients, as you can see, these patients are going to have a much larger kidney volume than you would expect, but they will have a good renal function, mainly because most of the kidney is still preserved, and these patients have normal renal function. In this case, in the cases that are atypical but atrophic, it's going to be the opposite. These patients are going to have smaller kidney volumes, but unfortunately, it's not going to be correlated with a normal renal function. So these patients are going to have small kidney volume, but they are going to have worsening of the kidney function much faster than you would expect for this kidney size. Also, patients that have a concomitant systemic disease that may be affecting the kidney are not eligible to participate. Patients that have diabetes. and patients that are taking an investigational drug or therapy for the disease, but also patients that may have a contraindication to or something that will interfere with MRI assessments, such as method prostheses that are not compatible with MRI, aneurysm clips, or that have severe claustrophobia. So what does participating in the studies involve? And since these are very similar studies in terms of what it is involved, I will present them both together. So both studies involve one visit to the clinic in Rochester that takes approximately 3 hours. It also involves not food or drink except for water after 8 p.m. the night before of the study. When you are at Mayo, you will have to first sign the informed consent, and then you will be asked to complete a health and a family history questionnaire. This questionnaire has simple questions such as your personal history. For example, have you had kidney stones? Have you had hematuria? How your family history looks like? Who are your family members that are affected with the disease? So, what are your activities, daily activities? If you are taking over-the-counter medications, those are the things that are involved in the questionnaires. It will also involve the collection of a urine sample. We will provide a container to collect the urine, and we will provide instructions on how you collect the urine. It will also involve the collection of a blood sample, which are 2 tubes for our laboratory test, and additional tube that will go to study the renal function and normal biochemical parameters. And finally, it will involve the acquisition of an abdominal MRI, which is without contrast. So, important information that you need to know. The risks to participants in the study are minimal, which is what we define as not having a greater risk than you will have in a normal day, or that it will arise from a normal visit to physician. Potential risk, though, may include a complication from the blood draw that could include bruising or discomfort. And also, there are no significance from the MRI, which I mentioned before, it's without contrast. And the risk of loss of privacy will be minimal. However, what are we doing to try to minimize these risks? So the blood draws are performed by an experienced phlebotomist at the Mayo Clinic laboratory using standard techniques to minimize all potential risks. And to ensure, because confidentiality is very important to us, all data is anonymized. It's coded with a patient study number, and everything is stored in a secure nephrology server, which is behind the Mayo firewalls. Only personnel that is involved in the study will have access to it. What are possible benefits for participating for these research studies? I had to admit there will be no direct benefits to you that are expected to result from participating in these research studies. However, the information that we learn from this research will benefit, well, we hope it will benefit patients with ADPKD in the future. What or how do we handle your samples, and what are we expecting to do in the future? Once we collect the samples from you, we carry it to my lab, and you become a number once we collect the samples. So nothing will be stored with your name. You will be assigned a study number, and everything will be stored with that number. We would like to keep your sample for future research, and we may need to use your sample in the future without additional informed consent. And this is a specific section in the informed consent that you may wish to check or not. The reason why this is important is because today we are investigating this, but These results may lead us to want to investigate something that is related to this, and we don't want to have to contact you again. And it is very important that we can use these samples in the future. We would also like to share the samples with other PKD investigators. It is really important. We are a close PKD community, so it is really important that we collaborate among investigators and facilitate the collaboration with patient samples. So, for example, other investigators that are studying different things can benefit from previous studies, and we accelerate the learning in persistent kidney disease. If we share a sample, this will never be shared with your personal information. Everything, if it's shared in a coded format as a number. So in summary, participation in the studies includes one visit that it's approximately between 2 or 3 hours to the clinic, review and sign the informed consent, the completion of the health and the family questionnaire, the collection of a urine sample, a blood sample, and the acquisition of abdominal MRI. This is our contact information, and please do not hesitate to reach out to me if you have any questions that are not addressed during this webinar. And I would like now to thank you all very much for attending this webinar, and I hope to see you someday at the clinic.
Thank you, Dr. Razabal, for sharing your research and all that information. We really appreciate it. Elise, we have time for some questions.
Excellent, thank you. First, I had a request to go back to the eligibility slide, Maria, if you don't mind. Excellent. So the first question was, can someone participate if they are on tolvaptan?
No. Unfortunately, let me, okay, I'm gonna, okay. No, if they are already taking tolvaptan. Yes, if they are planning on starting tolvaptan, we would like to enroll these patients since it is only one visit before they start tolvaptan. The main reason for this is because we would like to assess these markers in patients without anything that could potentially alter the natural course of the disease. And since tolvaptan is known to modify the course of the disease progression, we want to capture everything that happens without any interventions.
Excellent, thank you. What about someone who is breastfeeding or pregnant? Can they participate?
It's a tricky question. So there is no risk from this study specifically for a woman that is pregnant with the MRI. However, MRI is only indicated in pregnant women if there is a benefit for the patient. Since this study will not directly benefit the patient, it will not be ethical to enroll a patient that is pregnant. And so a pregnant patient shouldn't participate in this study. Breastfeeding, it's not a problem just because there is no contraindication from the MRI and there are no interventional drugs in the study. So breastfeeding is not a problem.
Okay. Also in the email, it mentioned that healthy volunteers can also participate. What are the eligibility criteria for that?
So for the NRF2, since we didn't know anything about NRF2, there were no normal reference values, this is a study that started actually a little bit before than the NOX4, and that is why we are enrolling healthy volunteers. And so basically in healthy volunteers, what we are looking for is first we enroll the patients and then we match the volunteers according to the same sex and within one plus minus year of the patients. So first we need to enroll the patients and then we can find the volunteers. Volunteers cannot have any family history of kidney disease. themselves cannot have any personal history of kidney disease. Other than that, of course, they need also to have the ability to provide consent, and they have to have a normal renal function.
Excellent. And how will I know if I have atypical PKD?
That's an excellent question. Usually the patients that we contact are patients that we have seen before, and we have images available for them, and we can determine, and based on that, we contact them and we invite them to participate. In the case of a patient that reach out to us, what we will first request is, or we will ask what the kidney function is, and we will ask whether they have been seen at our clinic, or if they have not been seen at Mayo, if they can, we can send a disclosure, a form that they can send us their imaging, and we can evaluate the imaging in here, and then we can determine whether they are typical or atypical.
Excellent. Another question, what is the time frame for enrolling the study?
So I would say, unfortunately, these studies have been badly affected by COVID. So everything is delayed, and because of that, we are extending our enrollment period. And since these are one visit only, I would say we can extend the enrollment for the next 6 months for the NRF2, and at least 8 more months for the NOX4.
Okay, I have someone who has a GFR of 61 and they are 37 years old. Would they be eligible?
Unfortunately, no, because for the NRF2, they can be theoretically, because they had to have about 60. However, for the NRF2, they need to be between 18 and 30 years of age. For the NOX4, they had to be above 90, but it's the one that goes up to 40 years of age. But at 37 with a 61, it will be in between, so it will not.
Okay. And what about someone who thinks they qualify for both? Which one do you think they should choose?
Oh, they can choose both. There is no rule that says that they cannot be enrolled in both. And we actually, so if the patient comes and it's eligible to be enrolled in both, we are not going to acquire 2 MRIs. We're not going to torture the patient for double the duration of the study. So we will use the same samples for both studies.
Fantastic. Any other questions about participating, about what this research looks like?
Elise, we do have a question in the chat to clarify. Did you say 8 months for the NOX4 study?
For enrollment?
Yes.
Approximately 8 more months.
And if you did fill that study up in 8 months, when would you expect to have the results?
After we close the study, it will take us about 6 more months to be able to process all the samples and have some results.
Great, so the faster we fill it up, the better.
Of course.
All right, I believe that's all the questions. Thank you very much, Dr. Roswell.
Thank you very much, Elise, Nicole, Chris, the PKD Foundation in general for providing this space.
Oh, you know what? I have one more question for you. Sorry, this popped up. Will participants have access to their MRI and blood work results?
So everything is acquired or collected for research, but patients can request to have their images sent to their primary care provider, but they need to send us the authorization that we can release those images. And of course, yes, we want to facilitate as much as we can these studies for the patients. So.
Okay, no more questions? Anybody have one more they want to type in real fast? All right, if there are no more questions, I just want to take another opportunity to thank you, Dr. Arazabal, for providing all this information about these studies. I know it's been very helpful to everyone on the call. The PKD Foundation appreciates the opportunity to provide education, and after the webinar, you will be receiving a brief survey, and we'd really appreciate it if you take the time to fill that out and give us your feedback. We will use that as we plan future topics for discussion, and make sure you include any topics that you'd like for us to address in the future. You can also send any questions or feedback that you have to us via email at pkdconnect@pkdcare.org, and we will get back with you as soon as possible. On behalf of everyone at the PKD Foundation, thank you for joining us. Have a great evening. Thank you.
Bye.
Thanks, everyone.